Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover the part 1 of Diabetes Mellitus series. This one's going to be related to classification, signs and symptoms, diagnosis, and a brief overview of treatment. So let's begin with a classification. In this part of the video, we would like to contrast the type 1 diabetes mellitus to the type 2 diabetes mellitus, which are the most common ones and the ones that you're going to be tested in the exam. We're going to discuss other types of diabetes mellitus further in this video, but let's begin with this ones. Type 1 diabetes mellitus, it is usually recognized as the insulin-dependent diabetes mellitus. It represents only 5 to 10% of diabetes worldwide, and it appears equally in males and females, and the age of onset is usually less than 30 years. Now, this one was usually recognized as the children, young patients, diabetes, but with the recent obesity pandemic worldwide, we're starting to see that type 2 diabetes is taking the lead in these patients. Now, keep this in mind. Remember, this is the insulin-dependent diabetes that appears in children, but being obese, overweight, it's going to increase your early development of type 2 diabetes, and it can appear in ages such as early as adolescent age. So although there's less than 10% of first degree relatives affected, it appears in 50% identical twins. And although it is showing you that it has a strong genetic components, it is not as strong as the type 2 diabetes. So keep this in mind for the exam, because if they ask you which one is the strong genetic related diabetes, that's going to be type 2 diabetes mellitus. Now, the pathogenesis of this one is the patients are going to have autoimmune destructions of beta cells, and usually they have positive autoantibodies to islets. And of course, there's going to be HLA related associations, and that's going to be B8, B15, DR3, and DR4. And remember, these patients usually do not have insulin production due to destruction of the beta cells, and these are the patients that are prone to ketosis. And we're going to discuss why this takes place in these patients further in this video and on the acute complications video for diabetes. Now, with type 2 diabetes mellitus, this one is recognized as the non-insulin dependent diabetes mellitus. This is telling you that they do not always require insulin as management, but they may need insulin. Now, 90% of the diabetes cases worldwide. So this is the most common one. It appears most commonly in males, and the age of onset is usually more than 40 years. But as I told you, we're starting to see lesser ages for these patients. Now, more than 20% of first degree relatives are affected, and 90 to 100%. This is the reason behind they tell you that this has a strong genetic component, presents in identical twins. Now, pathogenesis, this one is known, non-autoimmune. Patients are usually obese, and this is because the insulin resistance that these patients develop. These patients have insulin present, so they're going to be ketosis resistant. Moving on, we have gestational diabetes mellitus. With this one, we're going to discuss the risk factors. Remember that you want to avoid these patients when they are preconceptionally to have these risk factors in order for them to avoid developing gestational diabetes during the pregnancy. And so it applies for patients that are overweight or patients that have obesity, patients with advanced age during pregnancy, family history of type 2 diabetes, of course, and of course, previous gestational diabetes. The parity is also important. With more pregnancies, you have increased risks. With the fetus being male, there's also an increased risk, and that's because of the size of the placenta. And we have also other insulin-resistant syndromes, such as polycystic ovary syndrome. And of course, smoking is another factor that has commonly been associated with gestational diabetes. Now, for the pathogenesis, these are the two hormones, the human placental lactogen and the placental growth hormone, which are responsible for generating the insulin resistance syndrome in a patient that is pregnant. Now, physiologically, this is normal. In a healthy patient, this wouldn't have any disturbances for the glucose management because the patient is going to generate increased insulin secretion. Now, if the patient already has an insulin insensitivity, such as obesity, PCOS, or previous history, then this is an added factor that is going to increase your risk for developing gestational diabetes. And lastly, this one, the TNF, these are inflammation markers. They are elevated in late stages of pregnancy, and if the patient continues with the weight that they added during pregnancy and they do not return to their preconceptional weight, then they will develop increased inflammation with increased adipose tissue, and so the TNF is going to be elevated, and this is mostly the factor most associated with gestational diabetes and also with type 2 diabetes development a few years later after pregnancy. Now with the MODIs, MODI stands for mature onset diabetes of the young. These are usually autosomal dominant gene mutations, and they usually interfere with the insulin production, usually with the beta cells. Around 70% of them are because of mutation in hepatic nuclear factor 1 alpha, and they represent 2 to 5% of diabetes mellitus cases. If you see a patient that has less than 25 years, it's non-obese, and has diabetes, then you check for these. And if they're positive, then you have your diagnosis. It is a MODI. There's more, there's other types of MODIs, but these ones are the most common ones, the HNF 1 alpha mutations. And now with metabolic syndrome, this is recognized as an insulin resistance syndrome. So this is the highest end of the spectrum of the insulin resistance. These are patients that are generating diabetes. That's the reason behind it being exacerbated by obesity, because this further increases the insulin resistance. And now it is most common in women. There's certain ethnicities such as African Americans and Mexican Americans that have higher predisposition for this condition. Women are usually recognized earlier because of the development of PCOS and the development of acanthosis nigricans. This skin condition, the darkening of the skin, is related to insulin resistance, but it is most commonly seen in patients that have metabolic syndrome. For the diagnosis, what you need are these 4 parameters. The first one being the lipids. If the patient has 150 or more than 150 milligrams per deciliter of triglycerides and HDLs less than 40 in men, less than 50 in women, you have your dyslipidemia component. Patients may develop hypertension. There's also this abdominal obesity, and you may perform a waist circumference measurement, and this obesity is particularly pretty much associated with insulin resistance, and of course the intolerance to glucose, with the fasting glucose being more than 100. Recognize that this one is more than 100 and it is still not in diabetic parameters, but if the patient already has type 2 diabetes, then it becomes part of the diagnosis. Moving on, let's finish the secondary causes. For these ones, remember that everything that damages the pancreas may unfold as diabetes eventually. So cystic fibrosis patients, patients with chronic pancreatitis may develop diabetes. Patients with hormonal dysregulation such as Cushing's syndrome, pheochromocytoma, of course glucagonoma, and acromegaly may also develop diabetes. For the drugs, glucocorticoids, the same as in Cushing, if they are elevated, they elevate the glucose. Thiazides, remember, they develop hyperglycemia. They also elevate lipids and calcium. For alpha interferon, this one may damage the pancreas. Pentamidine also has the same effect. Antipsychotics, they generate metabolic syndrome. And lastly, protease inhibitors, remember, they can develop also a metabolic syndrome-like manifestation. And now for the signs and symptoms we have for type 1 diabetes mellitus, of course, polyuria, polydipsia, polyphagia, and weight loss, they are all in relation to having excess glucose in urine and, of course, not having enough insulin in the body. And, of course, these patients may present the first event, maybe diabetic ketoacidosis, and this is important because this is the way these patients present usually, and so they are presenting in an emergency situation. We're going to discuss further these acute complications in another video, but remember that these patients develop diabetic ketoacidosis because of the lack of insulin. And now for type 2 diabetes, this one usually has an insidious onset, and it can develop for years until the patient recognizes the following manifestations: recurrent blurry vision, patient with recurrent infections, and also the target organ manifestations. And that's going to be neuropathy, retinopathy, and nephropathy, and of course, coronary artery disease manifestations. And with these patients, the first event may be also an acute complication, which is hyperosmolar coma. It is not usually presenting in this way. You're going to diagnose diabetes earlier because of screening, because of other symptoms, but they may present with hyperosmolar coma. So let's finish with diagnosis and treatment. For the diagnosis, if your patient is already symptomatic, then what you should do is you perform a measurement of blood glucose right there, and if it is higher than 200 milligrams per deciliter, then you have your diagnosis: this patient is diabetic. If the patient is asymptomatic, then you have three pathways. The first one is you perform fasting glucose measurement on two separate occasions. If it is 126 or higher, then you have your diagnosis. The glycated hemoglobin, if it is higher than 6.5, it is also diagnostic, and the oral glucose tolerance test is nowadays rarely used, but it is diagnostic if it is 200 or more at 2 hours. Now, for impaired glucose tolerance, which are pre-diabetic patients, it is going to be everything that's in between a healthy patient and a diabetic patient. So that's going to be 100 to 125 for the fasting plasma glucose, 140 to 199 for the oral glucose charge test, and the glycated hemoglobin is between 5.7 to 6.4%. Now, the importance of these patients is that they need lifestyle changes, and if you do not address the situation, this patient is going to develop diabetes eventually. So you want to diagnose these because you can make some changes and avoid the development of diabetes. And lastly, for the treatment, this is going to be only an overview of what to do, but there's going to be further videos for in-depth information of these medications, and also a pro series for guidelines in regards to how to act in management for these patients. Now, for type 1 diabetes, it's pretty straightforward. You have to give the patient an insulin regimen, and that's going to address the problem. Now, with type 2 diabetes, your first and best, and this is demonstrated in many studies, is going to be metformin, and it has many benefits. It is what patients prefer. It has few side effects, and of course, it has greater benefit than other medications, and also the cost is pretty low. So this is your first choice. And after metformin, your choices are going to be less clear. You have sulfonylureas and thiazolidinediones, which are strong medications, but what they have is that they're also cheap medications, and you can add them, but there's certain specifications that you need to follow. Now, the incretin mimetics, these are very good medications, but the drawback is that they are used in injection. So there's newer oral medications, but for the most part, they're usually injectables. And now DPP-4 inhibitors, they have similar mechanism of action as the incretin mimetics, but not as much added benefits. And of course, the sodium glucose cotransporter inhibitors also have some other benefits. Now, for all patients that have diabetes, the most important part is that when you diagnose, you have to address these things: education, weight loss in these patients, introduce exercise, provide orientation in regards to diets with low-fat diets, low-carb diets, and of course, a smoking cessation to avoid early development of complications.